Queens, and Associate Professor of Clinical Medicine in Icahn School of Medicine in Mount Sinai. I have Dr. Mosammat Shirajim Munira. We know her Lopa Abba. She's an outstanding individual and always, come forward when it comes to teaching for our doctors, young doctors back home. She's the attending physician in the Division of Cardiology and Department of Medicine, NYC Health and Hospitals, Queens, Assistant of Queens, and Assistant Professor of Medicine in Icahn School of Medicine, Mount Sinai. I have, I can see Dr. AKM Manwarul Islam Bhai. Dr. Manwar Islam is Associate Professor and Head of the Department of Non-Invasive Cardiology in the National Institute of Cardiovascular Disease, Bangladesh. Manwar Bhai, thank you so much for joining us. I really appreciate you. You are always, the front runner in teaching and education for our doctors. I highly respect you for that. I have Professor Tamzeed Ahmed, the Senior Consultant and Interventional Cardiologist in Evercare Hospital, Dhaka, Bangladesh. I have Dr. Shakil Farid. He's a trustee of our PHA and the Consultant Cardiac and Aortic Surgeon, Royal Papworth Hospital, NHS Foundation Trust. So I have cardiac surgeons to keep us on track. And I have another cardiac surgeon, Dr. Said Asif Sadiq, faculty lead of PHA of cardiothoracic surgery. He's the consultant cardiac and aortic surgeon in Sheffield Teaching Hospital, NHS Foundation Trust. I have Professor Chaudhuri H. Hassan. Everyone knows him. He's a trustee as well, and clinical professor of medicine and director of cardiac catheterization and interventional, director of cardiac research, University Medical Center, Las Vegas, Nevada. I have Dr. Nasser Khan. He's the program director of cardiology fellowship program and medical director, structural heart program in Methodist Hospital, Dallas. I have Dr. Arun Muskie, who is the senior consultant in the Gangajal, am I saying it the right way? Shahid Gangalal National Heart Center. Thank you so much, Dr. Muskie, for joining us here. And we will hear and learn from you about the cardiac aspect of Nepal. And I can see Dr. Ghulam Azam Bhai. So Dr. Ghulam Azam is the professor of cardiology. He's the clinical and interventional cardiologist, professor of cardiology of National Institute of Cardiovascular Disease, NICVD. Thank you, Dr. Ghulam Azam, for joining this session. Am I missing anyone? This is a roundtable meeting, so if everyone you can turn on your microphone and camera and have a, chat and discussion about our preventive cardiology topics and things, and jump in any topic or any things that you say that we do it in this way or that way, particularly for your patient population. So I always say trial is a trial, and recommendations are recommendations, but not all recommendations can be implemented in our patient's life for different aspects. So we always have to take everything in an account and treat a person as a whole rather than as a book. With all that saying, I would like to open the forum for the discussion for all of us. I would like to invite Dr. Farshid Paraver to open up the topic or talk on preventive cardiology, and particularly his specialty is cardiac rehab and exercise things. Thank you.
Thank you very much. So one of the major things that patients need to know, and we providers, we should educate the patients about is exercise, because exercise has a broad range of health benefits. Actually, there is evidence that a sedentary lifestyle may be even a stronger predictor of mortality than the traditional risk factors that we always talk about, which is smoking, hypertension, diabetes, and high cholesterol. So it has been shown in the observational studies that unfit individuals are actually 2 to 3 times more likely to die during follow-up compared to their more fit counterparts. So exercise is very important. I'm just going to briefly touch down on 4 different types of exercise. One is aerobic or endurance exercise, which increases cardiovascular and respiratory fitness. The examples would be walking, running on treadmill, jogging, or swimming. There's the strength or resistance exercise, which increases muscular strength, like weightlifting, push-ups, pull-ups. The other 2 that are talked about less is one is balance exercise, which improves proprioception and balance and prevent falls. It's especially important for the elderly. And examples of that would be heel-toe walking and Tai Chi. And the 4th type is mobility or flexibility exercise, which maintains and improves range of motion. And that would be a stretching or yoga. The society recommendations is to have for all patients 18 years or older to have about 150 minutes of moderate intensity exercise, which is like brisk walking per week. So actually, this is so important that some society says it should be like physical activity vital signs. So you do blood pressure, you check the pulse. You should also ask the patient every single visit, how much do you exercise and what type of exercise you do. It is so important. And it always comes back to us, well, what are our medical clearance for exercise? Everybody can everybody exercise, or there should be a medical clearance before exercise? And recent thinking is to shy away from doing a exercise stress test on all the patients. Actually, the U.S. Preventive Service Task Force in 2018 recommended against routine screening with exercise testing. Having said that, there is a lack of consensus among different organizations because there are different patient population, the age and the risk factors and everything. So what is everybody agrees on is that symptom-limited exercise testing should be done in somebody who had chest pain, especially with exertion, somebody has history of dizziness on exertion, history of palpitation or dyspnea on exertion, or somebody who has orthopnea or PND. And more intensive evaluation for patients who may have significant elevation of blood pressure and pulse, because why do they have that before they start exercise? We need to treat that if somebody who has a murmur and somebody who has edema in the lower extremities. So having said that is more important than this, so we give them clearance to the patients to do exercise, but patient education before exercise is also very important. So it's very important to tell the patients that there should be a warm-up and cool-down. Warm-up, which means a lower intensity of the exercise they're going to do, about 5 minutes or so. This stretches the muscles, increases blood flow, increases connective tissue extensibility, and increases joint mobility. And the cool-down, which is about 5 minutes after the exercise, it prevents postural hypotension and syncope. It enhances venous return to the heart. And if the patient exercises and all of a sudden stop, quite often they feel dizzy and they may even have some deleterious effects. So cool down is also very important. The other thing that patients may ask, well, is there a difference between continuous and accumulated exercise? What does mean accumulated exercise? So is it important, we say 150 minutes per week, is it important to do like 30 minutes continuously in a day? Or is it okay to do like 10-minute intervals? And the studies have shown that accumulated, which means that 3 10-minute exercise duration in a day produces comparable effect of fitness, blood pressure, metabolic health, and survival compared to the continuous exercise. So that's important. And we should tell the patients every minute counts. So even a 10-minute daily moderate activity is associated with a 10% reduction in all-cause mortality in the patient. So we say every minute counts in heart attack, every minute counts in terms of exercise as well. The other question that may come up, so you're saying 150 minutes of exercise per week. What if patients say I exercise more? Is it better or is it the same? So the return on investment for more than 150 minutes per week gets lower and lower, but there is some benefit, but there has been shown that more than 100 minutes exercise per day doesn't produce any additional benefit compared to less than 100 minutes per day. So they shouldn't be really killing themselves exercising for a long period of time, but the best return on investment is about 150 minutes per week. And it's not necessary to do vigorous exercise. Again, observational studies have shown that subjects who walk about 15 minutes per day, just walking, have had a 14% reduction in mortality. And everybody talks about 10,000 steps per day, and the guidelines suggest a reasonable total step count, a goal for adults in a day is about 7,000 to 10,000. Another thing very important for patient education for exercise is to tell them about medical dangers, medical danger signs during exercise. And again, another observational study has shown that the athletes who experience fatal or non-fatal cardiovascular complications had a prodromal symptoms like chest pain, dyspnea, lightheadedness, decreased exercise tolerance days to weeks before they had the event. So we should tell the patients if anything changes, if you get short of breath easier, if you get chest pain, just stop exercising and contact us to see what's going on and advise them. So this is all exercise for primary prevention. Also, is exercise important for secondary prevention? So patients with chronic disease can benefit a lot from exercise. So like obesity. So obesity, dyslipidemia, diabetes, hypertension, kidney disease, arthritis, or even pulmonary disease, they can benefit from cardiac rehabilitation. One of the things that I'm going to touch on more deeply is cardiovascular disease. So,
this is Nasser Khan. I'm sorry, I'm going to interrupt you for a second and have a question. I might have missed that part. So when you advise your patients, I know there are studies for both, but what's your advice on aerobic exercises versus weightlifting or the combination of both? What's your take on that?
Okay, so aerobic exercise is the mainstay. So for example, in cardiac rehab, the first thing you do is aerobic exercise. Once they reach a goal and they're doing aerobic exercise, then resistant exercise also becomes important. I will touch on it when we talk about cardiac rehab. Resistant exercise especially can tone up the muscles. And for example, I'm talking about it a little bit later. For example, heart failure patient gets hospitalized, they get deconditioned, and because they're deconditioned, they walk less, they exercise less, they use their muscle less, so there's muscle wasting, and then they even use their muscle less, and it's a vicious cycle that goes on. So for these patients, even like some resistant exercise would be helpful. But the first step would be aerobic exercise, combined with some, once they reach the goals, combined with some resistant exercise as well.
Thank you.
So
Dr. Ragparpar, can I just, on that note, can I just ask you something? Is there a problem with vigorous exercise, like in marathon runners? There has been some studies of pro-inflammatory stuff being released and having endothelial dysfunction. So the reason why I'm asking you is if someone had CABG or stenting, they want to go back doing vigorous exercise, would you advise that, or do you think it's a bad idea?
There is no, like I said, there is no need to have vigorous exercise. A moderate intensity exercise will do it. Even, like I said, the study is just walking will be beneficial. Vigorous
No,
exercise.
my question is, does vigorous exercise cause endothelial injury? Do you think this theory is correct or not? I mean, I get what you're saying about moderate exercise and the benefits, but my question is, if you got a marathon runner and that marathon runner has revascularization, does that cause problem afterwards if he continues to do vigorous exercise? Like, I mean, I'm sure you have seen there are some
There's a
studies.
phenomenon called Federative syndrome. Extreme exercise comes from this guy. Thousands of years ago, there was this war between Greece and Persia, and this guy, walked like ran hundreds of miles and gave the news that Persia has won the war, and he collapsed and died. After his name is called the Federative syndrome. So acute intense exercise can cause RV dysfunction, and people can die from that. If you're asking that question, but that's a rare thing. So I don't think.
But endothelial injury, does it happen?
On that regard, and tell them not to exercise. I would like to know what Dr. Raj thinks on that, but that's one syndrome that's recognized.
Yeah, there is a syndrome. You're absolutely correct. There's a syndrome of over exercising, which could be actually deleterious. And especially if somebody, like you're saying, somebody has had revascularization, I don't think it's not necessary or maybe deleterious to have very vigorous exercise, in my opinion.
Thank you. I think it's very useful.
Make a comment. The issue is the name of the game is the coronary artery disease, and if we think about two ways, one is the primary prevention and the secondary prevention. Now the primary prevention group, and I think it is a problem, and sometimes I feel like danger that if we do a wholesale recommendation about any strategy without looking at the overall risk burden of an individual. And why I'm bringing this issue up, because vigorous exercise who already have some plaque, and there is plenty of evidence that can maybe actually accelerate the process, as you pointed out in your comments. So we need to be careful about what we are recommending. But I would like to highlight that what we know now from the different studies about the primary prevention and the conventional risk factors and the non-conventional risk factors. And then probably we need to think about a global approach for healthcare delivery system, and also as a clinician, the risk factor modification and reduction in risks and progression of the coronary disease to find from a starting point. For example, no question that all risk factors should be modified, right? We all agreed with that, aggressively modified. And then before we recommend any particular strategy, we need to individualize the diabetes, hypertension, hyperlipidemia, or is this person already scored by doing the calcium score and atherosclerosis already began, or somebody who is still calcium score 0, but early years in his life and has a cumulative risk of developing atherosclerosis later in life. So I think all these issues will come up. And to answer the question about vigorous exercise, I would be skeptical for recommending that it's somebody who already has atherosclerotic plaque burden. And I think probably, I don't know, the others in the panel will be to do things in moderation, but at the same time, addressing the risk factors that has impact on the pathophysiologic mechanism of atherosclerotic progression.
I would echo what Hafiz just said, and I'm sure you all will agree that whenever we try to tell our patients exercise, it's not like go suddenly and do intense exercise, because that, just like Hafiz said, that can cause acute plaque rupture, especially people who are not used to exercising. I have had several patients that who suddenly started exercising, went to the gym, and intense exercise came with an MI. Or, when I was in up north, people who are not used to any physical activity, there's the snow, they go out in shoveling snow and they have an MI because of the acute plaque rupture. So it's all about how, upping your level gradually increasing the intensity, but not all of a sudden and going an intense exercise. That's something we definitely don't recommend. Dr. Ratpapar, what's your thought on that?
Like a soccer game. You are before
Exactly.
this game starts, you need to know the rules and your vulnerability. But also important that within minutes of the starting of the game, that means your calcium score is positive, you know that you are in. You have to do the uphill battle. However, if the calcium score is negative, you are not immune. You still have to aggressively address the risk factors. And then the same thing will change as we grow older. Maybe calcium score at 70 is much more powerful than calcium score at 30. So we'll discuss more as we go in.
Yeah, and I should
Totally
emphasize
agree.
that all the recommendation from societies is not vigorous exercise. They're recommending moderate intensity exercise, and it is correct. They don't recommend going like off the bat and exercising for a prolonged period of time. They say start slow with low intensity exercise, and as you build up, get to longer sessions with moderate intensity exercise. I haven't come across any of the societies recommending vigorous exercise for routinely for all the patients. And like I said, obviously, a history and physical is very important, and risk factor that the patient has, and the warning signs, like I mentioned, like if you have chest pain, dizziness, palpitations, pedal edema, and very high blood pressure, these needs to be addressed in this population before you give them an exercise prescription. And every patient should have an exercise prescription. That is correct. Every patient is different, even for primary prevention, everybody is different. And I'll talk about what goal you get in terms of training heart rate when we talk about cardiac rehab in the next few minutes. So in terms of cardiac rehab, it's for secondary prevention, it's indicated for patients who have had a heart attack, have had angioplasty, anybody has heart failure, heart transplant, bypass surgery, or even valve surgery. It improves quality of life and speeds recovery. But like it was mentioned before, only 1 in 4 patients who qualify for cardiac rehab are referred to cardiac rehab. Why that is one is provider awareness and education. When I was in medical school and when I was in training, nobody was talking about cardiac rehab. Even now, my daughter is in medical school and just finished medical school, is in residency training. I ask her, anybody talk to you about cardiac rehab? And she says no. So it's actually a forgotten field. They don't educate people. We don't educate our training doctors that what cardiac rehab is and how important it is. And the second is that the availability, even in New York, which is very populated, in our area in Queens, there's only 2 cardiac rehab centers for hundreds of thousands of people, and a lot of them undergo all the procedures that we talk about. And one of the reasons that it's not available is because reimbursement is not that high for cardiac rehab. So there's no big incentive for medical centers to start a cardiac rehab program, basically. And cardiac rehab is not just exercise, also targets the other risk factors, smoking cessation, diet, weight management, the psychological support. Many of these patients are depressed because they went through a big life-changing situation like heart attack or having an angioplasty. It also involves, half of it should be patient education about the medications, why they're taking the medications, and exercise prescription that is safe for them and effective, and also to teach them about warning signs. When should you stop exercising and contact your doctors? I said that even studies in athletes said that if they had a fatal or non-fatal event, they had some symptoms or some prodromal symptoms days to weeks before it happened. So you should educate the patients. When they exercise, if they see anything different, just contact us and see what's going on. And cardiac rehab can be started the first week after the patient gets discharged, unless that's been a complicated issue. Obviously, somebody has had bypass surgery, you want some healing to take place before you bring them cardiac rehab. Somebody who had an angioplasty, you want the access site to be healed before you put them through cardiac rehab. But the studies have shown that the earlier you start after discharge, the more compliant the patient is going to be to follow up with cardiac rehab. So there are, in terms of risk stratification, I'll talk about 4 groups. One is class A, B, C, and D. A class A is an apparently healthy individual with no clinical evidence of increased cardiovascular risk. So they are doing fine. Class B is a clinically stable cardiac disease with low risk of cardiovascular complications during exercise. Class C is a moderate to high risk patient. These are patients who have had multiple MIs, have had a cardiac arrest, heart failure association, New York Heart Failure Association class 3. The exercise capacity is less than 6 METs, metabolic equivalents, and they have significant ischemia with an exercise stress test that's not amenable to intervention. So that's class C. And class D is the sickest patients, or patients who are unstable disease, have unstable disease and require a restriction of activity. So the patients who would benefit for cardiac rehab is not class A or class D, class B or C would be the patients who we can help in terms of cardiac rehabilitation. And like I said, cardiac rehab effects is to decrease their or modify the lipid profile, decrease the blood pressure, better diabetes control, weight loss. There's ischemic preconditioning. So if they have angina, if they exercise them, they get preconditioned and get less angina. And because of the collateral circulation, hopefully they'll do better, even if they have an event. It also improves endothelial function, and also is kind of a group support. When the 5-6 patients come cardiac rehab, they talk to each other. There's a group support, and it helps them a lot socially and improve their psychosocial status, basically. In terms of cardiac, sorry,
Dr. October. So in regards to this exercise, as you came up with that, with the exercise with lipid panel and all these other things, the smoking cessation and cholesterol levels, blood pressure goal, all these things when come into the point, delivering this whole package is probably the most important stuff towards our patients. And in that aspect, I think as we go and see our patients in our day-to-day life, sometimes it's challenging, but it's still probably touching all the points are sometimes difficult. But I think the way you sort of individualized person for the exercise and everything, that's really a great way to at least start for our patients. With that saying, if we want to talk about a little bit of cholesterol and in regards with exercise and all these sort of things, I would like to also ask some of my other panelists to jump into the LDL or cholesterol levels, how we are approaching to the cholesterol at current time back home in Bangladesh. If Dr. Manwar al-Islam is, I can see here. So how we are approaching in cholesterol level things, how people are aware, and I know there's a lot of resistance we sometimes see for taking medicines for cholesterol. How we are really educating our people back home in cholesterol things.
Thank you very much. Actually, you know that there are some special features of coronary artery disease in Bangladesh, and that also include just hypercholesterolemia, or rather to say dyslipidemia. And in Bangladesh, if we look back to the data, which is not so adequate, 1 in every 3 Bangladeshis adult persons are rather dyslipidemic. So it's a very big problem for us. And among the other features, this is also contributing probably to the high incidence of coronary disease, and especially the premature coronary artery disease in Bangladesh. And if we consider just in Bangladesh, the attitude is changing. Some people, as we see, that they are even very much cautious and enthusiastic regarding cholesterol, lipid, and control of cholesterol. But this is probably the tip of the iceberg. And the majority of the people are still not aware of the high level of cholesterol or triglyceride or low level of HDL. Whenever we are coming across the people, individual people in our day-to-day practice, especially for primary prevention, the educated people and those residing in especially the urban areas, they are often just motivated. And nowadays, some of the people are very cautious. They ask for the control of their lipid abnormalities. And whenever we advise, they often try to take the medicines for reduction of cholesterol. But a significant proportion of people also are very reluctant to consume any source of medicine. They sometimes ask for lifestyle modification, and they ask for the cholesterol-rich diets that should be avoided. Previously, a lot of people were very fond of the dietary habits that are to increase cholesterol or change the lipid pattern. But nowadays, people are conscious, and often the lot of cholesterol consuming foods are not consumed so commonly in Bangladesh right now. But still, the young generation is having the westernized culture and also the food pattern. And because of this, they are fond of fast foods and also the high cholesterol foods. And side by side, the other factors like the lack of physical activity, that is also a very big problem. And according to the last NCD risk factor survey, only a minority of the people in Bangladesh are habituated with physical activity that is beneficial. So these factors are also contributing to that. And if we look back to the community level, there are also problems with the dietary patterns in Bangladesh, especially other than cholesterol. The people of Bangladesh are also using especially the fried foods and also the fatty foods. And because of the consumption of fried foods, probably the trans fat content of the diet in Bangladesh is relatively high, though the data is not so adequate. And another important aspect is that the edible oil. In Bangladesh, the edible oil, the chief edible oil is soybean oil. But also people are consuming other oils like mustard oil to some extent, and also nowadays sunflower oil, and the posh people are using olive oil. Rice bran oil also are in use to a smaller extent. And among these oils, some people are also using palm oil, though this is not so popular in Bangladesh, but still they are consuming this. And among these, as you know, that the mustard oil, which is the just traditional cooking oil in Bangladesh once upon a time, but this is not right now. This is the chief edible oil. This mustard oil is having the high content of erucic acid, and because of this, previously FDA put a ban on this so that it could not be used as a cooking oil. But there is a lot of ongoing controversy regarding this. And another habit in Bangladesh is that those involved in cooking food at home, they are often reusing the cooking oil. And because of the reuse of cooking oil, just to save money, and because of the reusing of cooking oil, a proportion of the fat within the cooking oil is converted to trans fat. So the trans fat content is getting high. And regarding the snacks commonly consumed in Bangladesh, like shingara, samocha, puri, and other traditional foods, they are often deeply fried. And because of the deep frying and during the process of deep frying, often the trans fat content gets high. So I think these are also the hidden dangers in relation to the dietary fat in Bangladesh. We are often addressing cholesterol, we are often addressing to some extent triglyceride, but not to these things. So these factors should also be paid due attention so that we could have a good dietary habit or heart healthy dietary habit at the community level as well.
Thank you.
I have a question for you. So, you mentioned that people in Bangladesh are reluctant to take the statin medication. This is also a common problem here. I spend half of my time convincing people to take their statin medications because statin for some reason has a very bad press. And people think, statin causes a lot of problems. And the most common problem, they come up with muscle ache. They may have muscle ache from other reasons, but they always think it is the statin that's causing the muscle ache and they stop taking the statin medication. So, I have a hard time convincing them that the data has showed it's only 7 to 10% that you will have true muscle pain from statin medication. So more than 90% chance you will not have a problem. So my question for you is that do you, and all these studies are done in Western population. So if from your experience, do you see like true side effects like muscle or other problem from statin in Bangladeshi patient population?
Thank you, Nasir Bhai.
Also just want to add one more thing to add up this discussion here. So regarding this statin, and here Dr. Tamzid is here from Evercare Hospital, and the reason I kept him here along with my other panelists here, because the patient population, what we see sometimes in National Health Foundation, NICVD, and Evercare Hospitals are sometimes different. We know all about that. So what do you think in your patient population, both to Dr. Tamzid Ahmed and Dr. Monora Islam and Dr. Ghulam Azam, the statin, the drugs, is it the financial aspect of it that sort of people resist in that, or is it the side effect of the part which people resist to take it?
I just do my sense.
Dr. You're muted. Would you mind?
Sorry, Ramashrami, thank you. Actually, it's a good question. I mean, the spectrum of disease, basically the same population will have the same, but socio-economic status is different in different hospitals we see patients. Particularly in our private centers, yes, there's more people from more economically solvent. They do come here and they usually tend to practice, take medicine more often than the poorer ones. So in a sense that we do have problems like most of the common problem with the use of statins, as you mentioned earlier, Dr. Nasser, is myalgia or muscle pain. And some patients who goes abroad have done their interventional surgery, they come back with high dose of statin. And their main complaint was not any angina or anything, but more of muscle pain. So here in Bangladesh, giving high dose of statin is a problem. I mean, generally the general population wise, their structure is less. I mean, no, we are smaller size people and our muscle mass is low. So statin may cause a little more myalgia, not necessarily high race CPK, but myalgia from statin. So the use of statin, higher dose of use of statin is lower in Bangladesh compared to Western world. And then again, there's one paradox is there. We have lower level of LDL compared to Western population, but we have higher triglyceride in our population. Maybe particularly for the sedentary population we see in our city life people, they have a less physical activity. They have a more carb diets, and resulting in higher triglyceride levels even than the LDL. So LDL wise, we are somewhat not very high, those who are taking statin, and obviously maximizing the dose of statin sometimes becomes a problem. But of course, it's a question of convincing the patient. So if you increase the dose of statin, then if they, to the best of that they can tolerate, then you can add ezetimibe or other medications to reduce the side effect of statin. That can be practiced. We sometimes do that. So in general, as I say, the spectrum is a little different from the Western population, and because of we see a lot of diabetes is very common in Bangladesh, and so is the small vessel disease, and and the pattern of lipid abnormality is more on the triglyceride side. LDL also high, but more of triglyceride. We so see such a high incidence of high triglyceride, which is lesser risk factor than the LDL cholesterol, of course. But then again, we do see patients with very, very high triglyceride levels.
What about in Nepal, Dr. Musky?
Yeah, yes, like in Bangladesh, we have issues of high triglyceride, and one interesting finding which we find in our hospital setting, I work in a National Heart Center, you will be surprised, is 20% of the MI patients are less than 45 years. It's very interesting. So we get a lot of young patients. That's very disturbing. And most of these patients, if you look at the risk factors, mostly smoking is very high. And regarding that miles and other problems, we tend not to use a very high dose of statins in our setting because the body builds are quite low. Maximum we would use is around rosuvastatin 20, maybe atorvastatin 30 to 40. So we are a little conservative regarding use of statins, and cost is an issue. So what disturbs us is we are getting more younger patients I work in tertiary care centers, and that's very disturbing. And 30, 40, 20 to 40 years are very common. So I don't know whether, and if you look at the data from South Asian countries, they say Nepal, India, Bangladesh, the incidence of coronary artery disease is 10 years before. So that's also more disturbing.
Do you think this is only because is it there are some genetic characteristics that we sometimes see that apolipoprotein or LPA levels, those were in the particularly South Asian countries have higher tendency to have those. And question to all of you again is other than the statin, the use of fibrate, niacin, or that omega-3 fatty acid, which is the EPA, how are we doing on those aspects? Are people aware about other medications than statin, which can also affect some triglyceride levels? Since it's like triglyceride is one of the bigger player back home for cardiovascular issues.
Yes, we do prescribe. Sorry, if someone else is talking, please carry on. We sometimes combine statin with a fibrate, obviously, and that's to reduce the triglyceride. Of course, emphasizing on more of exercise, carbohydrate, and oil reduction in their diet. But then again, we end up with increasing the dose of fibrate. Yeah, sometimes in combination, sometimes causes more myalgia and liver dysfunction. So we have to balance between two side effects and effects.
So,
is it recommended to use combination of drugs like statins and fibrates? Is it recommended?
It's not really about first line recommendation, obviously. When it comes to LDL, there's no question of any fibrates. But with the population we face with very high level of triglycerides, we have to target on triglycerides sometimes. Sometimes with the primary prevention, we have triglyceride of 300, 500, or even 1,000, and with low normal LDL, like below 100. So we rather use them on a fibrates rather than a statin in first line of defense. But those, of course, as coronary disease or higher risk factors, statin is, of course, a first line of drugs.
So I just wanted to make a comment because the original question was how you target the reduction of cholesterol, particularly targeting the LDL. I think that was the question from Dr. Mashrafi. So my comment is that secondary prevention and primary prevention, we all agree that the statin has a significant impact in primary prevention. But it has two issues. The way I look at one is that it's the national level, is a mass education and cholesterol education program. But when it comes to the clinician, it also depends on the individual patients, because humans are not like Tesla cars, that one problem and you change the software, all cars will be okay. We need to look at the individual risks and individual, the mechanism why the LDL. For example, somebody may have a heterozygous, hyperlipidemia with LDL high, and somebody may have a diabetes uncontrolled and LDL high, and somebody may have a LDL high with recent stent. So what is the target we are aiming for? So if we look at the altogether, the TNT, prove it, the lower you go, the better. But how low you can go? Is there any impact in terms of affecting cognition? One of the Chinese studies showing that those with the stroke and then aggressive reduction, maybe a little bit of hemorrhagic chances higher. All these need to be taken into account. But my 2 cents on this will be that, yes, if it can tolerate it, lower is better. 1 millimole, meaning like 39 milligram per DL here, is a 20% reduction, roughly. And the ESC is championing that very, very aggressively. And we should aim for that. And if you look at the reduce it, the triglyceride also important. And first line would be to use medications like Vasepa to combine with that, rather than statin with fibrates, because of the side effects may be higher. So that's my overall view. I don't know anyone has any comment, because
Yes.
human biology individualization is very important as well.
Hafiz Bhai, as you pointed rightfully, the ESA is very strict about it. Their very high risk group is less than 55 milligram per DL. For high risk group is less than 70, and low middle risk is less than 100. So these are very strict guidelines for ESC, from ESC, and stricter than American College. So it's sometimes very impossible to follow that guideline for our population, particularly as a primary prevention. And with some side effects we do see, of course. But as you said, of course, as far as they can tolerate, keep on increasing the dose of statin until we have the desired goal of the levels of LDL. So 55, 70, 100, these are the different levels we have to achieve on different patients. So the risk of the population, higher the levels of statin and lower the levels of LDL. That will be our goal, of course. And of course, those who can't tolerate statin fully, then you have to go for the other medication, azacitidine. PCS9, actually, we don't have it in Bangladesh, to be honest with you. So we don't have any experience. Do you have any experience with that drug? There's a
PCSK9 we use it, and then also the recent one is inclisiran, the mRNA technology. These are the drugs that has significant impact, particularly those with the statin intolerant, and where you actually need more reduction. The lipid lowering drugs are like antihypertensive. If somebody's blood pressure is 220 and 130, you don't just stay with hydrochlorothiazide. Similarly, if there is a LDL is 190 to start with, you don't just think that statin alone will be the only thing will cut it. So we need to be realistic, particularly the context, if there is any other risk factors, and how to get that LDL down. And technology has to be cheaper. And that is something we should look forward to, because the inclisiran or the PCSK9 inhibitors, these technology, if they become cheaper, maybe we'll be embracing them more than we are doing now.
So in regards to this,
Sanjit Ahmed, I'm going to just answer your question. So the PCSK9, actually, I was involved in the initial trials with that. So I have quite a bit of experience. The patients tolerated it very well. It's an amazing result in lowering the LDL. The only issue is, kind of Hafiz Bhai mentioned, is the cost. So it was in the beginning, it was very prohibitive. It could be like easily $14,000 a month. It's unbelievable. I'm sorry, a year. So now the cost has come down and we are using it a little bit more. But patient tolerance wise, it is much better tolerated. I do not have any experience with the recent CLEAR study came out in the last SCC, the bempedoic acid. I don't have any experience with that. I don't know if you have or anybody else has that, any experience. I would like to know.
Can I ask one question? I just came with one problem. The lady, wife of my friend, he came with a report of lipid profile. Everything is fine. LDL is triglyceride, everything is fine. SDL level is above 65, 70. So now he's asking question, is this too good or is too bad or what is that? Anybody has any
What was
comments?
the LDL again, Professor Muskie? What was the LDL?
LDL was normal around 110, something like that. So SDL is above 65, 70 milligram per
Right. Now
deciliter.
we have this data that, that the curve, the too high LDL is not good either. That's what
No, SDL is too high.
Yeah. So I
So
would like to
now
know
the
other
question
aspect
he was
of it.
asking question is, what should I do? I tried to search literature. I did not get any answer. So in this forum, if anybody can suggest.
First of all, the HDL high is not good. There's a report, you've probably seen this, but the HDL in those observation was way high, meaning HDL is above 80, 90 milligram per DL. But your patient luckily is in probably the healthy high HDL group. So I would not worry too much. And then if you want to know first that how old is the patient, what are the other comorbidities?
Nothing.
And then, yeah, then you can probably not need to worry about, and particularly how old is the patient?
Around 60, 55, 60.
Actually, this is a good case to start with a calcium score. If the atherosclerosis has not begun, then you can probably just address the risk factors.
There's no risk factors.
Yeah, then sit tight.
Yeah.
And I would not worry. HDL 65.
There is a group of people with genetic predisposition of high HDL, and some of them are in good health, exercise and stuff like that. But here in the Western world, we do see some people who have like just genetically, they have high HDL.
Those are like 80 above. HDL like 80 or 90 milligram, not in the 60.
No. Hafiza, I'm talking about the healthy population that you just mentioned, that who have the genetic predisposition, they have high LGDL and they are doing just fine. If the patient is asymptomatic in this range, I would not do anything, just like you said.
Dr. Maske, can I ask one thing to you?
Yeah, sure.
What is your primary goal actually? What your goal is to prevention, primary prevention or secondary prevention?
No.
If patient don't have any risk factor, because any management strategy should be lifelong strategy. Suppose if you look at the patient when a person born from the intermittent life, fat history is there, and it is over coronary fat history is expressed in 10 years, then over the year, the multiple factors influencing to develop atherosclerotic disease. So that's why question come in front, the primary prevention and secondary prevention. But if you patient don't have any risk factor, so you don't have to worry. You just searching and follow up every year for find out the risk factor, because age is also risk factor, sex also risk factor, any other additional risk factor if you have, then you can achieve your target, because you have to treat your patient to achieve your target. If you had a history of coronary artery disease or bypass or stenting, and you have suppose LDL 60 or 65 like that, or SDL 65 and LDL suppose 70, your target according to your clinical situation and other risk factor consideration, you have to set a goal, how much LDL or HDL goal you are achieving. So if record too much statin record, you should add. If it is come down, suppose you are maintaining cholesterol LDL level below 70 or below 55 by 40 milligram rosuvastatin or 80 milligram atorvastatin, it's okay. After follow-up, subsequent follow-up, if you achieve it within 40, it's okay. If after follow-up, subsequent follow-up 20, it's okay. You just target to maintain your goal. So I think every patient should be individualized. Every patient is unique, and you set a goal for every patient and individual. Remember, once a patient develops atherosclerotic disease, it is no real cure once it is developed. So we have to follow up the patient and try to measure every time, every 3 month or 6 month interval. And if any deviation, then we can interfere it. I think it's my recommendation from my side. On the
Thank you,
top of
Dr.
this, two fundamental things we have to remember: dietary approach and exercise, which is nicely covered by our first speaker. And a lot of usual actually discussion still is remain to discuss more in regarding exercise. We'll be happy to address it. Thank you very much.
Thank you, Dr. Azam. Thank you for. I will come back to this coronary artery calcium thing because this is looks like this is going to be an important thing, as well as blood pressure. I will ask Dr. Lopa to address that once, but I just want to give a little floor to my cardiac surgeons, and we have two cardiac surgeons from UK. And one important thing for our lifestyle is smoking, particularly back home in Bangladesh. Now we have seen alarming rise of smoking, particularly, when we were in back home, probably was not as prevalent in female, but nowadays I think a lot of data are coming out of smoking, particularly in female. So with that aspect, what sort of thing that we mostly get with smoking is definitely the atherosclerotic disease, but also aortic disease. So what are the recommendation currently for smoking or the smoker group? Definitely the smoking cessation is the number one intervention or counseling, but also for your recommendation about your heart and aortic things from my esteemed surgeons.
Asif, you're on mute, I think. We can't hear you, Asif. We can't hear you. Yeah, now we can hear you. Yeah. Asif, again, it's on mute, I think.
Oh, shit. Can you hear me now?
Yes, we can. Thank you, Asif.
Okay, thanks. I think my thing was just playing up. A couple of things I want to mention, and just because today's topic was about primary prevention of cardiovascular disease and the risk and the death. And I think what we want to understand, and what I actually wanted to get through our panelists as well, is that we have got two groups of risk factors, modifiable and non-modifiable. And we can talk about those modifiable risk factors as much as we can. But as a cardiac surgeons, and I think Shakil Bhai would agree, we're seeing a huge number of patients absolutely fit and well, good healthy lifestyle, especially in UK, never smoke, never drink any alcohol, normal diet. Even I've seen a huge amount of vegan patients coming for surgeries. And I think these are modifiable factors. And one of the important things is the genetic predisposition, which is actually an important factor for this group of patients to have either high risk of cardiovascular disease or atherosclerotic disease or peripheral vascular disease. And I think as a surgeon, and the second group of patient that we see is a valvular heart disease patient. And I think the most important thing in this group is the education and awareness. Dr. Monor Islam was highlighting that, and I think from Bangladeshi perspective, medications we can talk about a lot of time, but I think the education and awareness, that's where we're really lacking. Even in UK, I have to say, the part of the UK where I work, socioeconomically is not as good as like the southern UK. So there is the education and awareness is in a really, really bad stage. People coming in a very late stage of their heart problems, and they are most of that not like the majority of cases we see sometime they are inoperable or they can't even have any treatment just because of their late presentations and not being aware of their cardiovascular problem. So this education and awareness, I think it should be very important. The second thing regarding the smoking, I mean, it's a huge number in UK, and also not only smoking, as you know, vaping has come, and that has increased in the younger population. So we are encouraging the young generation, the teenager, to start vaping because we're saying that that's not as risky as the smoking, but is actually absolutely wrong. And this has shown, especially chemical irritation and pneumonitis, the multiple case reports and evidences has been coming out. In our practice, particularly other than coronary, as we know, the smoking is an important factor, but the aortic disease, there is a huge amount of patient we see for aortic aneurysms. And one of the risk factors are actually smoking. And there are a huge number of patients who are on surveillance list. And one of the advice that we gave them, that if you continue to smoke, unfortunately, the risk of aortic dissection ruptures will go higher until unless you stop that. So then there comes again the the education and awareness. And I think this is where we have to really step up. Say it's in Bangladesh or in America or in UK, this needs to be where should be our primary goal to achieve. Because we know we tend to talk about medications and all these things long time, but until unless we educate our populations, I won't say patient, our general population, the awareness of the prevention, because there will be modifiable risk factors. We can do a lot of things, but these unmodifiable, they will come with heart problem. So early diagnosis, prevention, and if we do early diagnosis, referral for proper treatment, and the early intervention can make their life, and I would say they will prolong their life. Sometimes it is inevitable they will get heart problems, but if we can intervene in the right time, we'll definitely will be able to give them the best possible outcome.
Now, we know that when we are talking about smoking and aortic disease, we have some recommendations for males. But now we see the alarming rise of smoking in females. Is there any particular recommendation there? And if not, why not?
I mean, one thing,
yeah.
Shakil bhai, yeah, sorry, you go ahead.
No, I just didn't want to interrupt. The thing is, I think that's a very good question. So interesting thing is, whichever part of the world you live in, the modifiable risk factors are always modifiable. And we actually are really bad at doing primary prevention. So I always lived in a very affluent part of UK, fortunately or unfortunately. I will give you a very good example of the Oxford Vascular Study. Oxford Vascular Study looked at around 100,000 patients with aortic dissection, and they looked at the risk factors. You know, big chunk of them were smokers, current heavy smokers. But one of the most interesting thing was more than 46 to 47% patient had a blood pressure of over 180 before presentation. So, you know, all these modifiable risk factors, smoking, hypertension, all these things are really important. Now, going to the guideline and recommendation, yes, you should stop smoking before you undergo surgery. And hopefully you won't start that after undergoing surgery. But unfortunately, it doesn't work that way. Most of the patients who are current smokers and heavy smokers, you hardly see them stopping smoking. Maybe the smoking rate of smoking goes down, they take less cigarettes and things like that. But it's a huge problem. It's a huge problem not only for developing coronary artery disease, but also for the aortic disease, as my colleague has said. So, you know, I mean, primary prevention is something which is lacking even in the developed world, not only in the developing countries. Now, the second thing I wanted to say is a little bit regarding the rehabilitation. There has been really good discussions about target LDL level and ESC guidelines, all these things. We all know that statins actually have anti-inflammatory effect as well. So following coronary artery bypass grafting, it's really important for the patients to be on high dose of statin immediately in the post-op period. So, you know, at least for a few months following the operation, if they're on high dose of statin, that does actually reduce the inflammation on the heart, and graft patency becomes better as well. You know, there are some studies, and, you know, these are very difficult to prove because of the dosage, what happens with the 20 milligrams of atorvastatin, what happens with 40, those things are difficult to understand. But we all know that in the setting of recent ACS, it's really important to be on high dose of atorvastatin. And a little bit about rehab. I think our esteemed colleague from USA very nicely and eloquently told about rehab. I think that's one of the things that needs to be developed, especially in a country like Bangladesh, because it's almost non-existent. What we have noticed, like I work in Cambridge and we cover around 250 miles. So a lot of the patients are actually in remote areas, which is 100, 150 miles away from Cambridge. So how do we do the rehabilitation for those patients? As you know, the NHS capacity is really bad, and some of the local hospitals have very skeleton service and they don't have the service of proper rehabilitation. So in our experience, we have seen that if the patients are educated about cardiac rehabilitation whilst they're in the hospital, immediately after the operation, they're more receptive to ideas and advices, and they're given videos for home rehabilitation. And we have actually published from our institute, I was involved in that study, that if you have two groups of patients, one group having institutional rehab, another group having home rehab with video assistance and with telephone calls, their outcome is actually good as well. So I think those are the things we need to think about going forward for Bangladesh, because resources are very limited. And it doesn't take much to create videos and talk to the patient and give advice regarding that. So on that note, I would like to finish my speech and thank you very much once again to all the panelists and Mashrafi, as always, for his brilliant moderation. Thanks.
The issue of smoking is to some extent different in Bangladesh. Smoking is a problem for males only in Bangladesh, and this is virtually non-existent in females. And you know that right now the prevalence of smoking is almost 50% in Bangladeshi males, adult males. I'm talking about, and for females, consumption of tobacco is almost 33%. They are not using smoking, but they are accustomed with different types of tobacco products like jorda, even the raw shada pata, like these things. So,
and passive smoking is a big problem as well. Passive smoking.
Passive smoking is a big problem because the male counterparts are smoking and the females often are in the environment of smoke with them.
Yes, Dr. Monor, there's a little change nowadays. I can see.
Monor, I'm not agree with you. If you look at the
other places, females are smoking more than the males, young males, half of our age, of course. This younger generation, there's female generation, they're smoking more, actively smokers, they're becoming active smokers. But in terms of MI, we're still seeing younger males than the younger females because other risk factors, of course, and of course, hormone. So altogether, male are sufferers always, more than the female.
So we have Dr. Lopa to address a little bit comment on that women's heart or women's health and heart conditions. And if you kindly address a little bit of blood pressure targets as well, that would be wonderful.
Yes, thank you, Mashrafi. And before that, actually, before I start my talk about that topic Mashrafi mentioned, I have a question actually for the interventional cardiologist and the cardiothoracic surgery. As because you know that we live in Newark, which is a very high immigrant population, especially we have a lot of population from the Asian part, like Southeast Asia, and especially Bangladesh, Pakistan, and India. And as Dr. Atpawar knows, whenever we see any patient in our EDOU, like emergency department observation unit, any chest pain comes with, even it is a very atypical symptom like burning or pricking type, still the population from Southeast Asian, we get scared of and we don't discharge any patient without any kind of test, at least even it is a no risk factor, as Dr. Asif was mentioning, like absolutely no risk factor, very atypical chest pain, we prefer to do at least a stress test. And if it is little bit even typical, we send for cardiac cath. And a lot of time we found that they have triple vessel disease and end up with CABG. This is a very, very high incidence here that we observe. So my question will be to the there was actually, when I was doing fellowship also another part of the Newark, over there, all like we used to get a lot of Bangladeshi patients. So our program director and chief of cardiology, as soon as we start presenting and with the name of the patient, he will say, oh, it smells CAD. Whenever it's a patient name has Chaudhary or Khan or some Bangladeshi or Pakistani name, that he will start, oh, the name smells CAD. So is there such thing that not only genetic, because we started actually a research at that time, it was his observation that a Southeast Asian population has the narrower coronary. So if the same amount of coronary plaques may be making 30 or 40% stenosis for a white or African American population, or same amount of plaque for the Southeast Asian, because of the narrow coronaries, it's making critical lesions. Is there anything you observe, whoever is familiar with more with the both kind of population? Is it true?
I mean, I would just add on this, and I have to say that it's really clear, as you mentioned, that because the part of the UK where I live, there is lots of migrant populations are there as well, and there's lots of people from the Asian areas. And the moment we see that name, we know we're going to looking at a very bad coronaries, and that's what the case is. And most of my Western colleagues would really get scared to operate on these patients, really, with these horrible coronaries. And I think, as you mentioned, I think this is the important thing. Our coronary arteries are actually small, generally. And that's why even a small amount of disease causes a significant pattern of a symptoms, or the disease load is more significant because of the artery size. Like when we, especially me and Shakil Bhai both, we operate on aortic aneurysms, and those group of patients, they're usually very tall and they are very big, and their coronary arteries are like a massive railwork. And even if you got a 50% disease on those, they never get any symptoms because it's such a big arteries. They actually don't get any symptoms from there. I think this is one of the factors.
Is it because of the BMI body size, or is because of the genetics?
I would probably see it's more about the race, like gene related, rather than the BMI, because it's not all the case, but I think it's our in generally genetically the way we have been grown or we have been developed is the case. We have got coronary arteries in. On the other hand, our brain arteries are much bigger than the Western populations.
I mean,
May I just correct one thing?
Vessels are very
Actually,
confusing.
Southeast Asia represents Malaysia, Indonesia, Thailand. We are the South Asians, which are different from the Southeast Asians' anatomy. So Southeast Asians have a bigger anatomy. I mean, they have less coronary disease compared to South Asian, which like India, Bangladesh, Pakistan, Nepal, they are the South Asian countries. So we have the worst kind of anatomies, coronary disease as well.
Very diffusely diseased vessels.
And I think for us, there are a couple of individual molecules also quite higher than rest of the world, probably, which is like apolipoprotein and LPA. Those are also quite prevalently high in our Southeast Asian country or South Asian country population. So when you look into the, there's a guideline for LDL or a lipid guideline in USA, you see that there are additional or risk enhancing factors which are mentioned, and one of the risk enhancing factor is being a South Asian population, and
that's right.
And that's one I think that's one of the reason. And also those among those risk enhancing factors, we talk about that, the LDL, the lipoprotein A level, apolipoprotein B level, all these sort of things that we can help us to individualize our decision making to counsel people whether they should start taking statin or not, or they should take higher intensity rather than moderate intensity.
So there was a postulation before called Indian gene. There's a starvation gene or Indian gene. I mean, I know that actually we have something like that. We call Indian gene or starvation gene. So in 1,000 years of deprivation and causing this a new coronary disease, neointimal proliferation, more common in this, as smaller vessel disease are more common in this, who has changed their lifestyle pattern over years. We used to have vegetables in the past. We used to walk a long distance in a village life, but in the sedentary ambulance and this city life, it's totally different from the village life. So we have seen the peak of rising cholesterol, coronary artery disease, and to extent like a pandemic situation, you can say, rather endemic situation, epidemic in epidemic proportion, you can rather say.
Exactly.
So that's actually.
Mashrafi, and everyone, if you kindly excuse me, I have another meeting to attend in 5 minutes. Before I leave, I'd like to thank you all profusely for your time, and it's been lovely seeing you all. And best of luck with the meeting. I just have to, leave now. Thanks, everyone.
Thank
See you
you.
later,
Thanks,
Shakbhai.
Dr.
Bye.
So
Professor
there are,
Tamzin, I just wanted to sort of add on to you, because you have touched
Please.
the most important point here, because the coronary artery anatomies, genetic factors is one thing, but our lifestyle, I think, is the most important at the moment, especially in in Bangladesh, the people who live in the cities area. We are completely have gone away from the walking, exercise, and the diet. So these factors is a very important factor for us now. Even if we think about the people who live in UK, I mean, we do walking, exercise, but our diet is still the same. And I think our dietary practice is also not the healthiest one if you consider the amount of oil and the trans fat we take in our diet. So this is what I think it's all about, this education and awareness, that because we are, ourselves is a risk factor. So being us is a risk factor itself. So now if you are yourself is a risk factor, then you really need to think about all these things and have to treat early. And as we're talking about the secondary preventions or primary preventions, there should be a lower threshold for us to have treatment rather than any other populations.
right. Thank you so much. I know it's getting late. It's already 1.5 hours almost. We're talking. I just wanted to add just two things and quickly. One from Dr. Dr. Farshid Parapar and Dr. Shirajim Munira Lopa about two things. One is the blood pressure goal and aspirin for the primary prevention type things. We know there's a lot of talk and a lot of media coverage about this primary prevention of aspirin. Should we use it or not? And there are a couple of questions on that particular things came up in our chat box. And secondly, the second question would be to Dr. Manwar and Dr. Azam about the calcium score. And I think I see Sadia here, who she is a radiology from Massachusetts General Hospital, about how, if the question is whether the calcium score is really being used, or is there a scope of doing it in back home, and if not, is there any way we can help to use it as a modality back home, and how successfully that we can do it if Sadia gives us some idea about it. Okay, so we'll start with the my first question, Dr. Shirajim Munira and Dr. Ratparavar.
Okay, I'll request Dr. Ratparavar to answer the aspirin question after me. And so blood pressure goal, and I wanted to talk about, actually, I kind of being a only female panelist here, I would like to talk about a little 2 minutes about the women's health. So actually 1 in 3 women dies from cardiovascular disease each year, and it takes actually 500,000 of women's life. Usually we think about breast cancer, but breast cancer is like 1 woman dies in breast cancer in 30. It kills 1 in 30 women, and CVD, coronary vascular disease, kills 1 in every 3rd woman. So, which is actually that CVD kills more women than the next 7 causes of death combined. So this is the #1 killer. That is very, very important. Usually, most of the time, like after the menopause, the coronary vascular disease it rises 2 to 3 fold after the menopause, and the prevalence is more in the African American and Asian population. But unfortunately, study shows that 21% of the women view heart disease is a life threat. So 21% women only thinks that heart disease is a life threat, even though it was once upon a time, it was labeled, heart disease was labeled as a widowmaker. We know that ST elevation MI was labeled as a widowmaker, means the only man's die from the ST elevation MI, and woman becomes a widow. That was the concept decades ago, even that it don't touch the female, which is not true at all. So that's why we have to take the action, whatever prevention, the modifiable risk factor we talked about, we should be taking care of man as well as female also. So that was the reason actually the American Heart Association made a program of Go Red for women, which is celebrated each year on the first Friday in February. And it has the phrase of Go name as an acronym actually. So I just want to finish this topic with that meaning of that acronym. So Go Red, G-O-R-E-D. G is the get your number, means check your blood pressure and know the number, what you are belong to. O is own your lifestyle, means stop smoking, lose the weight, exercise and eat healthy. And R is for realize your risks. Like always we think about it won't happen to us. It can happen to everybody else, not with me. So that is not true. It can happen to me as well. So realize your risks and educate your family. Educate your family regarding the healthy food choice for you and your family. And the last one is the D from the Go Red is don't be silent. Means tell every woman, you know that heart rate is our #1 killer. So go check your heart. That will be for the actually female. And Mashrafi requested another, the goal of blood pressure. I want to say that there is at least 10 society has 10 recommendation to the cutoff limit of the blood pressure, like American Heart Association, American Stroke Association, European Society of Cardiology, American College of Physicians, American Family Practice. So there was when I was searching, actually, it was like at least 10 kind of societies making 10 kind of recommendation. So finally, I came up with the solution that American Heart Association and American Society of Cardiology and the Stroke Association, these three societies actually combinedly made a recommendation, which is the main guideline was published, I think, 2017. And then finally, the goal was set as a less than 130/80. There is a lot of classification like we call, so there is a little difference with the European Society guideline. European Society guideline, the elevated blood pressure started from the 130 to 140 and the diastolic is 180 to 90. So their recommendation is less than 140/90, but American, all the society came combined in 2020 that it should be, no matter what is the risk factor, means the CKD, diabetes, coronary artery disease, and whoever is more than 65 years of age, it should be less than 130/80. And as per European Society guideline, less than 140/90. I think there is a 10-point difference. The American Society is little strict about maintaining the blood pressure. The reason is they wanted to start the counseling patient, especially the point we are talking about the elevated blood pressure, not really counting as a high blood pressure, which is 120/30. That is the point actually we start to intervene. Means, the lifestyle modification start from the one, if it is more than 120, but European Society guideline level to more than 130 as a elevated blood pressure. That was like American Society guideline, actually little conservative because they wanted to start the lifestyle modification little earlier. So they set a lower number to start the lifestyle modification earlier to prevent to go to the high blood pressure. And only thing actually that is the only difference. I would say like all the society came up to 2020 that less than 130/80. Only there is a little flexibility regarding two category of people. One is like CKD. We all of us, we know that it is actually very hard to control the blood pressure for a CKD patient. So CKD patient, they said maybe it will be reasonable to keep less than 140/90 for CKD patient, and also for the elderly patient more than 80 years old, it is reasonable to keep less than 140/90. This is the only two group was exception on that all the association guideline. Otherwise, it is recommended to keep less than 130/80 as per all the American Society guidelines. So
Thank you.
that was the only thing. So and that's all. I think I had a lot of actually kind of slides, but I think we are too short with the time. So that is the summary. And
Thank you,
the
Dr.
question for the aspirin, maybe Dr.
Aspirin.
Lapavara can take over.
Okay, in regards to aspirin, there was a lot of dilemma in the past. Should we use aspirin for primary prevention? And the American Task Force updated the guidelines recently, and they recommend against using aspirin in patients older than 60 years old for primary prevention. For patients 40 to 59-year-old, you should calculate the risk, the 10-year risk of events, and if it's more than 10%, then you should start aspirin. Secondary prevention is obviously a different story. If somebody has a coronary artery disease, they should be on aspirin.
Thank you, Dr. Ratparavar, about this thing, because I wanted to just particularly bring this topic for one reason. When these new trials, which are in the last 5 years, got published in the scientific journals, there is a tremendous amount of media coverage about it, but the biggest thing that they missed mostly did not focus on whom are we really giving aspirin and whom we are not, or recommending against or for. So, as an interventional cardiologist, my patient population is probably the biggest one who already have coronary artery disease and may have stented them or treating them with medicine. Many of them came back without aspirin because even the primary care physicians stopped their aspirin after that media coverage. So that is the biggest thing that we always have to keep in mind, that these recommendations are for individuals without diagnosed coronary artery disease or known coronary artery disease. These are primary prevention, not for people who already have coronary artery disease. So that is the big difference here. So all the primary care physicians, individuals, and healthcare workers just would like to keep that in mind, that primary prevention, that means there is no coronary artery disease, or at least not significant risk. We do not recommend nowadays aspirin, or if you, in a younger population group, you have a good discussion about it. For a senior group of people, we do not recommend it anymore, but these are only primary prevention. For secondary prevention, aspirin is still something that we recommend, particularly if you do have coronary artery disease, you have stents in your heart, aspirin should be something that you need to be on. Thank you, Dr. Paravar. And lastly, I would like to just go back to Dr. Manor and Dr. Ghulam Azam about usability or the trend in Bangladesh. Do we really use calcium score, or is there any scope of doing it back home? How it is being utilized nowadays?
Thank you. Actually, calcium scoring has got incremental value for risk assessment, no doubt. But in most of the tools that are used for assessment of the 10-year risk of atherosclerotic cardiovascular disease does not include calcium scoring as a routine practice. And in Bangladesh right now, using CT coronary angiography is in the rise. And just in Dhaka city, a good number of centers offer CT coronary angiography. But the problem is that isolated calcium scoring as a part of CT coronary angiography is not so popularly or commonly done in Bangladesh. Only 1 or 2 centers offer this. So this is rather underutilized in this country right now in 2023. But I think this has got a big prospect in future. And for this, we the clinicians have to be aware of the potential utility of this tool. And if we are aware and if we advise to our patients for incremental value of risk stratification, then certainly this may be done. And it may virtually cost 3,000 taka or like this, whereas a complete CT coronary angiogram at least costs nearly 14,000 taka in Dhaka right now.
Dr. Azam, or I'm not sure whether Dr. Azam is still there or not.
Shafi,
Yes.
exactly
Dr. Azam,
what
thank
you
you.
said. But still it is underused, number one. Number two, we are too much reluctant because if you think the cost issue, it is angiogram is in our center 2 to 3,000 and CT angiogram, it is 14 to 15,000. So, but it is very important to use CT angiogram and calcium score. Actually, we are the very less people are practice very less people because especially if you think 1,047 cardiologists, among them we are 300 plus interventional cardiologists. Among them 10% only, interventional cardiologists of 10%. That means it is less than 30 people sometimes use for calcium score for our patient. So I think in course of time it will much more popular because we are trying to involve our all people and what is the exact need for further risk stratification, it will be helpful. So we hope it will increase in course of time. That is my comment.
Thank you, Dr. Azam.
I have
And
got a comment.
yeah, sure. Thank you. I was just looking for you.
I'm on call, so I heard part of the talk. Thank you so much for organizing this. About calcium score. Sorry, the people who don't know me, I'm Sadia, one of the cardiovascular imaging staff. I work in Massachusetts General Hospital. So we use calcium score a lot here. And as Monar Bhai said, that it has got incremental value in predicting cardiovascular risk. And it's, it adds so much to the traditional risk scoring system that even on MESA study, Birmingham study, it has shown that how it affects, 10 years MACE. And also that's a completely different topic, but what I want to say that I think, first of all, we need to make the cardiologists aware that it has got huge value. It's very easy to do, although it's 2,000 or 3,000 taka in Bangladesh. But if you think about the long-term aspect of, stratifying patients correctly and putting them on right treatment. The other aspect I think is if you show a patient that this is your heart, if you have a picture of calcium score in front of you and show that this is your heart and this is how calcium is building in your coronaries, I think there will be more adherence to statin therapy because it's kind of visual impression of your heart and your coronary status. And I think compliance will go up if you, at least the patients who can afford, you can do calcium score. The other thing is the negative predictive value is very high, even in younger patients. So 10-year mortality, most of the cases is less than 1% if you have zero coronary calcium score. So there are some positive aspect as well. Someone who has got a borderline level of lipid, doesn't want to take statin, and calcium score 0, probably there is a chance of absence of other risk factors, chance of stopping their statin. They don't need the statin. So there are a lot of other aspects. So we can go through calcium score probably in another talk, maybe in one of the cardiac radiology sessions. But I think first thing is to make the cardiologists aware the importance of calcium score in primary prevention.
Thank you so much. I really appreciate your one questions to all, including Sade as well. Like, so one of my patients I did a calcium score. And then I sort of convinced him to take a high intensity statin. So after 6 months, his LDL level came down. And now he asked me this question: if I repeat my calcium score, is it going to go down or not?
No, it is not.
Right.
It will not go down. In some cases, it may go up because statin will stabilize the non-calcified plaque the patient might have, which can't be seen on calcium score study because it picks up the higher density pixels. It doesn't pick up the non-calcified plaque. So yeah, there's a potential of missing, for the people who are not very familiar with calcium score, missing non-calcified plaque in a very small number of population, which is not statistically significant even. So the calcium you have are picked up, and with statin, the non-calcified plaque may go stabilized, and the score may go this like pseudo increase of score, but it will not go down. So for the people who are compliant with the medication, but you want to follow up with another calcium score for, particularly Western people, you can take the strategy of doing like in 3 years time, do another calcium score and show them that you are not compliant or you need different types of statin or other PCSK9 inhibitors or something like that to improve your cholesterol level. You can show with another calcium score that it has gone up. And yeah, it will not go down.
Right.
Maybe
So I
we can
told
explain to
whatever-
patient that it is not the size of the calcium we are seeing on that picture. Maybe we need to explain more to the patient that it actually stabilizing that plaque. So not to get the adverse effect from the plaque. It's not the reason to take the statin, not to go down with that calcium plaque, but
Right.
make it safer for the heart.
Yeah, I broke his heart. I said that whatever calcium you have, it's for you forever for you with your
Yes.
heart. That's it.
You can offer him coronary CT angiogram and show him you don't have any significant stenosis. So yeah, to reassure him. And
Thank
you're
you
not
so
going to die in next 5 years from a heart attack. So that insurance you can give him with non-obstructive coronary artery disease.
Yes.
So
With the
what will be
CTA.
your recommendation if coronary CT angiogram required 15,000 to 16,000 taka, coronary angiogram doing 2,000 taka? Which one you recommend in
So
high risk group patient?
definitely calcium score. Don't go for CT coronary angiogram. So
No, high
for
risk. If you go for clinically significant disease, atherosclerotic disease, atherosclerotic risk calculator, Framingham risk calculator more than 20%. So do you
Yeah.
still prefer 2,000 taka or 15,000 taka?
I would prefer 2,000 taka because patient is asymptomatic.
2,000
you're telling
taka.
me,
So
right?
we have go for invasive coronary angiography. We are going
Oh,
to
invasive
invasive angiography 2,000 only.
It's up to you. I don't know, but
Nah, the person who are
invasive
not too much
angiography
high
is not.
risk,
Yeah.
if we calculate by different calculator, online app-based calculator like atherosclerotic risk cardiovascular disease risk calculator, then Framingham risk calculator, Reynolds calculator, you can use it. Then you can manage it. If it is not, then you can reclassify and then go for calcium score. And actually, we are what group of patients we are recommending? The people are not. We are thinking it is not a risk of coronary disease, but patient insisting he has a coronary disease. That group of people we are choose to go for CT coronary angiogram.
Okay, no, definitely. CT coronary angiogram is a huge thing. Please join me in November. There will be talk on CT coronary angiogram with a cardiologist. And we can talk in details about it. But patients for risk stratification, you don't need coronary CT angiogram or invasive coronary angiogram. We are talking about prevention.
No
so
risk. This
you can
not
add
the people who are very high risk patient. You are suspecting
Yes.
patient might have coronary disease.
Yes.
That group of people should go into coronary invasive angiograph, because if we are thinking he is a low risk patient insisting me he need to go intervene, then we
Okay.
recommend for CT coronary angiogram, not invasive angiogram.
For
Okay.
low to
Okay.
for low to intermediate risk category,
Right,
CT
right,
coronary
right.
angiogram plays the best role, but for high
Yes.
risk, certainly invasive coronary angiogram. But still, the indication of CT coronary angiogram, including calcium scoring, is rapidly expanding, and I think this will be even on the move in future.
No, expanding
Definitely.
Manohar. It is expanding in not in our context. It is expanding in Western context. In our context, only 10% people we are using this. So you
Reason
see,
There are other-
what I mentioned,
Our CTND is
1,084
overpriced.
cardiologists, 300 interventional cardiologists. Among them, only we are the 10% people are prescribing. Not in every case, in selective cases. So we hope
there
it will
are-
increase.
There are
But
other
the problem
reasons.
is that we the physicians have some inertia,
Right.
and we have to overcome this for the great interest of our
because
patients.
a lot of tests you have to order, at least blood sugar, ECG, echo, or blood lipid profile. So people are already exhausted. That's why we are some extent reluctant. Otherwise, actually, the person who are able to do it, we definitely order this patient because we are treating patient. We are considered the patient benefit, not other things. So
As like all the evidence, we are reluctant to use SGLT2 inhibitors in most of the indicated patients.
no,
And
my
this is
practice,
a big
I
problem
think my practice
for the world.
100%, but not it is
Because
applicable to all.
you are a dynamic
No,
cardiologist, but
no,
I
no.
am talking about cardiologists in general that despite
The
a
cardiologists are
robust
doing right now, but
evidence,
in general physician, like suppose medicine people,
even
sometimes
not
they are worried.
cardiologists, even the
Yes,
cardiologists are underusing this. So
yes. General cardiologist, general
yes,
cardiologist.
yes, yes.
Coronary
Yeah,
CT
fantastic
angiogram, I
thought. It's
just want to
not always being practiced in our country, but it's gradually picking up, of course.
Yeah, I just want to add on that there are some technical factors in there. So you have to produce a really high quality image where when you say that there is no obstructive coronary disease, the cardiologist, like the imager is saying there is no obstructive coronary disease, the cardiologist has to take in on board and don't go for an invasive cath. It has to be that reliable and reproducible. So the quality of the scan and the interpretation by the reader has to be um, at a very high level. So those are the other aspects that remain. So that's why probably some of the cardiologists are not that keen because they have had experience in suboptimal quality or suboptimal result where
That's
there
very
was
true.
like, they said there's nothing, but actually there's obstructive coronary disease. So we have to be aware of the limitations of scanner, scan, and reader as well for coronary CT angiogram. So the reason I'm emphasizing on calcium score is because it's very cheap, of course, non-invasive, doesn't involve any contrast, and is kind of easily available in terms of most of the centers where the CT scanner 64 slices, they can do it. So that's why I'm emphasizing on. But CT coronary angiogram for intermediate to high risk patients is very important as well. But that's a different topic of discussion.
Thank you so much. I would like to thank and appreciate everyone for your time and effort in taking part of this discussion. This is a big topic, preventive cardiology. I know it's never ending. Each and individual things would be like hours of discussions, but bringing these things together, I just wanted to have an exchange of views, how we are thinking about it, and where we can really go more. As I mentioned at the very beginning, that preventive cardiology is probably the least discussed thing with our patient population many a times. It's not in Bangladesh only or Nepal only. It's in US and UK, as you could see it from our different cardiologist perspective. We all have different geographical populations and different race and financial socioeconomic conditions of populations and patient populations. So it sometimes it's difficult to implement things on different aspects, but if we can gradually start towards a little bit of more preventive cardiology, I bet that would bring more value to the life of our patients, to the value of the whole community, all population in general. With that saying, I want to thank all of you for being here on this long and lengthy talk. And next month, I'm trying to get a big a session on smoking cessation only. That would be one thing that I wanted to do for Bangladesh at this point, and understanding there are quite significant rise in smoking habit, both in male and female. And I do not know how much we have things for Bangladesh population for smoking cessation in regards to health. So we will get some um, uh, smoking cessation experts from here to help and to exchange some views hopefully next month. with that, I would like to end or finish our talk here. I want to thank Dr. Shirajim Munira Lopa. I want to thank Dr. Ferdinand Ratparab. Sorry for that.
That's okay.
That's okay. You know, it took me 2 weeks to practice that pronunciation after joining there. So don't worry about
Sorry,
it.
I'm
Just 2
sorry,
hours.
that
That's
Farshid is much easier, but
Yeah, we call him Farshid. That is like.
Yeah, that's right.
Yeah.
I would like to thank Dr. Manwar for being with us. Dr. Tamzid Ahmed, thank you so much. Sadia, thank you so much for your, always be there. Dr. Ghulam Azom, I know a few of our panelists probably had joined another meeting on Sunday. I appreciate all of your time and hope forward.
I want to thank you, Mashrafi. It was a wonderful moderation. And that whole discussion was so learning for me. I learned a lot. And thank you so much for inviting us. And special thanks to you.
Thank you. Thank you.
Great job. Great job.
You did a great job, really.
Thank you.
Thank you.
Thank you, everyone. Stay safe. Good night for Bangladesh. And
Good night.
Good night from Nepal.
Bye.
Bye-bye.
আজিম ভাই আসসালামু আলাইকুম আজিম ভাই কি আছেন